A patient has a total knee replacement. No VTE prophylaxis ordered. Everyone assumes someone else handled it. Without prophylaxis, that patient has an 84% chance of developing a DVT. Not 8%, 84. That's the highest risk number in this entire video, and it's sitting in the chart right now in a hospital near you because prophylaxis got assumed instead of ordered. I'm Dr. Anderson, this is Note to Pharm.D, and today we're covering VTE prevention, how to actually risk stratify, and when extended prophylaxis is worth the bleeding risk. We're covering risk-stratified prophylaxis across the spectrum, from orthopedic surgery, which is genuinely the highest risk setting we deal with, all the way to the medically ill. And we'll get into special populations, plus when extended, post-discharge coverage is actually worth the bleeding risk versus when it isn't. Let's start with why orthopedic surgery gets so much attention. Without prophylaxis, over 50% of these patients develop a VTE. That's not a subgroup risk, that's the majority. And it's not uniform across procedures either. Knee arthroplasty runs the highest DVT rate, while hip fracture surgery carries the highest PE rate. Different mechanisms, different monitoring priorities. To actually operationalize this, use a validated risk tool rather than a gut instinct. Caprini score for general and non-orthopedic surgery patients. Padua Prediction score for hospitalized medical patients. These aren't optional add-ons. They're how you translate "this patient seems higher risk" into an actual prophylaxis decision. One more piece. Mechanical prophylaxis has a narrow, specific lane. It's best reserved for patients with active bleeding or genuinely high bleeding risk with a clear plan to transition to pharmacologic prophylaxis the moment homeostasis is secured. It is not a substitute for pharmacologic prophylaxis in patients who can tolerate it. The numbers that anchors this: 84% DVT incident in total knee replacement without prophylaxis. Intermittent pneumatic compression needs 18 hours of daily wear to actually show efficacy. Miss that, and you're not getting the benefit. And a Padua score of 4 or higher is your flag for high VTE risk in medical patients. Practice Pearl. That 18-hour figure is the one nurses and patients push back on the most because IPC sleeves are genuinely uncomfortable. If you're the pharmacist fielding that complaint, it's worth knowing the numbers yourself. Compliance below that threshold means the patient isn't actually protected, so it's a real clinical conversation, not just a comfort issue. DOACs have genuinely earned their spot in orthopedic prophylaxis, and it's worth knowing why. Rivaroxaban and apixaban weren't just non-inferior to enoxaparin in hip and knee arthroplasty trials. Rivaroxaban actually showed a superior reduction in VTE events at both surgical sites, and apixaban matched that specifically in hip replacement. Here's the caveat though, and it matters for how you interpret these numbers. The major bleeding definitions in these trials excluded surgical site bleeding. So the safety picture looks cleaner in the published data than the full clinical reality. That said, apixaban's combined major plus clinically relevant non-major bleeding advantage in knee replacement was real and statistically significant. That part holds up, even accounting for the definition quirk. The line to remember from the guidance: rivaroxaban has shown a superior reduction in VTE events compared with enoxaparin in both hip and knee replacement surgery. Superior, not just non-inferior. That's an unusually strong result for this drug class. Apixaban's story is a little more nuanced, worth knowing. It didn't quite reach the statistical non-inferiority against enoxaparin twice daily, specifically in knee replacement, even though the actual event rate were nearly identical, 9% versus 8.8%. That's a good reminder that a trial missing its statistical target isn't the same as the drug not working. Read the actual numbers, not just the p-value headline. Now, the populations that actually change your dosing decision. Severe renal insufficiency first. Enoxaparin drops to 30 milligrams once daily for a creatinine clearance under 30. Fondaparinux and rivaroxaban are outright contraindicated below their respective cutoffs, so don't reach for either reflexively in renal impairment. Obesity is the opposite problem. These patients need a bigger dose, not just a bigger question mark on the chart. Enoxaparin 40 milligrams twice daily or 0.5 mg per kilo twice daily is reasonable for a BMI 40 or a weight over 120 kilos. In pregnancy rules, DOACs out entirely, no exceptions. Low molecular weight heparin or low dose unfractionated heparin covers the full pregnancy, and warfarin is contraindicated, especially in that first trimester window. Key numbers. 35 days is the extended prophylaxis window after orthopedic surgery. 0 DOACs have any role in pregnancy, and 2/3 of post-discharge VTE events happen within 30 days of leaving the hospital, which is exactly why extended prophylaxis is even a conversation worth having. One more scenario worth flagging. A pregnant patient with a mechanical mitral valve, which we touched on last video, she still can't use a DOAC, and warfarin is generally avoided throughout pregnancy, giving the congenital abnormality risk in the first trimester specifically. Low molecular weight heparin is her therapy for the full pregnancy. That overlap between our valve video and this one is exactly the kind of cross-topic questions that shows up on this round, or shows up on rounds in general. Let's talk through the Magellan story, because it's a great example of how a trial result gets refined into something clinically usable. Magellan initially showed rivaroxaban cutting VTE events versus enoxaparin in medically ill patients, but with significantly more major bleeding at day 35. That triggered a subpopulation reanalysis, removing 5 identifiable bleeding risk groups: active cancer, dual antiplatelet therapy, recent GI bleed, and a few similar factors. Once those patients were excluded, the bleeding signal disappeared entirely, while the VTE reduction held, and the prospective MARINER trial then confirmed it directly. With the right patient selection, extended rivaroxaban prophylaxis is both effective and safe. The key takeaway quote: in the refined subpopulation, VTE events were significantly reduced with rivaroxaban, and major bleeding was not significantly increased. This is the whole lesson of extended prophylaxis in one sentence. Patient selection is what makes or breaks the benefit-risk equation. 3 takeaways to close this out. 1. Match your prophylaxis intensity to a validated risk tool: Caprini for surgical patients and Padua for medical patients, rather than clinical gut instinct alone. 2. Renal function, obesity, and pregnancy each demand a specific dosing adjustment, and DOACs have exactly 0 role in pregnancy, no exceptions. And 3, extended prophylaxis genuinely works when patients are selected carefully. Exclude the active bleeding risk factors and the benefit clearly outweighs the risk. That's VTE prevention. Next up, we are treating the clot once it's already happened. Diagnosis, treatment strategy, and how long therapy should actually last. If this was useful, like the video, drop your questions below, and subscribe so you don't miss it. See you next time.